We're good. Okay. Good afternoon, everyone. Good morning and good evening to those who are listening to us online. My name is Cecile Oger. I'm a managing director at BSR, a global non-profit organization working with large businesses on creating a more just and sustainable world. Delighted to welcome you in this beautiful place today. Today's session, we're going to talk about access to healthcare, accessible healthcare for all. You may wonder, why do we have to do this in 2022? Could think that everyone around the world has access to healthcare. Unfortunately, there's still half of the world's population who doesn't have access to essential healthcare services. And it's not just an issue of the low middle income countries, it's actually an issue that we're seeing everywhere across the world in developed and developing economies. The root cause of poor access to healthcare are many, too many to list. They go from very low levels of diagnostic, to poor health literacy, to limited R&D focus on some of the essential diseases, to weak healthcare systems across the world, poor management at country level, logistics inefficiencies, pricing and affordability issues, and the issue goes on. The list of issues goes on and on and on. It continues to be one of the biggest global challenges that we need to sort out today, and it's a challenge that demands system-wide change. So this is what we're going to talk about today. We're going to explore solutions and ways to address the changes that are needed. More particularly, we're going to look at the role of technology, the role of innovation. We're going to hear about new frontiers and new solutions. We're going to see how entrepreneurship can be part of the solution. We'll discuss the role of the different actors and the different ecosystem that we need to come together. We'll do this in three big parts. We'll welcome the WHO Foundation to set the scene. We'll then have a panel with three very viable solutions, and including one very large company and two much smaller but getting bigger. And then we'll have a fireside chat with Ilara Health. So we are now very ready to dive in, and I would like to welcome Anil, Soni to the stage.
Thank you,
Anil. I'll introduce you and I'll let you go. So Anil is the CEO of the WHO Foundation. He has 20 years of experience in global health and private and public sector. His career is really focused on expanding access to healthcare in low-income countries, trying to tackle market failures and exploring the role of business in finding new solutions. Today he's the CEO of the WHO Foundation. He leads a team of changemakers who are looking at ways to engage businesses' core competencies to tackle health inequities. He's going to introduce the foundation, but also set the scene for today, introduce the role of innovation and technology, talk to us about health inequities, and yes, set us all together for the stage for today. Anil, you have 18 minutes.
Okay.
Thank you.
Thank you very much, Cecile. Welcome, everyone, to those in the room and those online. And in particular, thanks to everyone who's organized ChangeNOW. We're on stage only because of all of the people who invited us and make this possible. So to all of you, thank you. My goal in this first part of the session that Cecile is moderating is to talk about why health, what health inequity is and why it matters, how it manifests, some stories of hope to address health inequity and inequality, and what you can do. And because of the persons you're going to be hearing from after me, I'm going to focus particularly on those first two subjects, why health and what health inequity is. And I'm going to do so by asking you to participate. So this is a participatory keynote address. And I'm going to ask you to use your imaginations and to think about people you love. So let's start with why health. All of us in this room are children. We are siblings. Some of us are parents in our chosen or given families. And I'm going to ask each of you to think about someone you love, whether a child, a sibling or friend, or a parent, someone you love, one of the people you love most in the world. And let's go through and think about these people that we love and why health matters. I'm a father. I have a son who's going to turn 1 on June 1st. His name is Rohan. When my wife was delivering, it turns out that an umbilical cord, my son's umbilical cord, was wrapped around him. And she had to have emergency C-section. My son is alive, he's thriving, but it's because she had the ability to have access to that obstetric care in that moment. That's what good healthcare is. So for those of you who are thinking about a child, imagine what it means for that child to not have access to good health care. In low-income countries, the risk of a child dying by the age of 5 is 10%. 1 in 10 children born in a low-income country does not make it to the age of 5. In a high-income country like Paris, it's France, it's 1 in 500. So there's a big difference between the risk of a child living, literally just living, depending on where he or she is born. We have a friend, my family, a woman who has 2 daughters. They're living with HIV, both the daughters. If you're born living with HIV and you don't get access to medicine, the chance of dying by the age of 2 is 50%, by the age of 5 is 80%. The medicine to treat a child living with HIV is $60 per year. But many children who are born with HIV don't have access. So why does health matter to children, other than feeling morally outraged that a child doesn't get to live depending on where he or she lives? The reason it matters is because everything follows life. Education, growth, a person becoming who he or she can be, fulfilling their potential. A society depends on their children being safe and healthy. That may seem obvious to you. What may not be obvious to you is that actually child mortality is also associated with population growth. This is something I'm sure this conference is talking about, the impact of population on the environment. It turns out when you have lower risk of childhood mortality, women don't have as many children. You have more children in certain parts of the world because you don't know whether your children are going to live or die. So it actually decreases population growth to decreased childhood mortality. So that's the reason why health matters for children, including for some of you, the child you were thinking of. What about siblings and friends, adults? I have a cousin. In the South Asian culture, cousins are considered siblings, so I hope you'll allow me to call her my sister. Her husband woke up recently and couldn't see out of one of his eyes. Went to the hospital. Turns out both his kidneys have failed because of a genetic mutation no one knew about. So he's now on dialysis, and hopefully he's going to live a long life because he's going to get an organ transplant. They live in San Francisco. They have good access to healthcare. They live in a country where her employer provides access to healthcare. And while kidney failure, particularly double kidney failure, is rare, having some kidney malfunction is not, and you'll hear about this. 500 million people in this world live with diabetes. If you live with diabetes, you need access to insulin. Some people have access, some people do not. Why does it matter, health, for adults, if you're thinking about a sibling, a friend? If that friend that you're thinking of is living in a place where he or she gets tuberculosis, or even worse, drug-resistant tuberculosis, they can't go to work. If you're not healthy and you can't go to work, that has an impact on economy. And many countries like to measure their progress based on GDP output. And so for those economies, health is wealth. And we saw this very particularly in the case of COVID-19, which cost the world trillions of dollars. I think the latest estimate is $10 trillion of economic loss. Health is wealth when we think about adults. But it's not just children and adults. For those of you who thought about a parent, in my case, I was thinking about my dad. My dad in 2009 was diagnosed with a cancer that has no cure, but it had a treatment. The treatment cost more by weight than gold. And yet he had access because he was living in a place with good healthcare, with good insurance coverage, and my dad got to live another 12 years. He died this January, but not of cancer. Why does that matter? My dad was retired. He wasn't contributing to the economy. He wasn't a child. He didn't have his education ahead of him. Well, it mattered because this is life. It's my dad. I want to spend as much time with him as I can, and health is a right. In fact, the countries of the world signed a treaty, too bad it was 75 years ago, saying that health is a right and everyone should have access, because that's why we're here, to love each other, to spend time with one another. That's why health matters. So whether you were thinking about a child, whether you were thinking about a sibling or friend, whether you were thinking about a parent, for everyone we love, health matters. It's a starting point to the rest of life. Okay, now let's talk about health inequity. I'm going to split up this room to demonstrate something. So for those of you on this side, my left, your right, and then those of you here on your left, my right. So I'm going to say the righties and the lefties. And I'm going to point to a couple of people just to make a point. You, sir, who are wearing the green jacket, what's your name? Christoph. Okay, Christoph's on the right. And you, sir, with the blue shirt? Michelle. Christoph, you're on the right side of the room. Let's say everyone in this room is diagnosed with HIV. Tens of millions of people have HIV. Think about that for a second. You woke up last week, weren't feeling so well, went to the doctor, turns out you're living with a virus. That virus is totally treatable. Okay, Christoph is on the right side of the room. You go to the doctor, and the doctor says, Christoph, this is really hard news, but there's a treatment for you. 1 pill, once per day, it's free. You get to live a full life. Christoph and everyone on this side of the room, you have access to medicine. Michelle, you're on the left side of the room. You don't have access. You live in a place where when you go to the doctor, they say, I'm sorry, the medicine's too expensive. Do you know how much the cost of that medicine is? $30,000 per patient per year. That's the price of HIV medicine. We just don't have the money. You don't have access. Everyone on this side of the room, the left side of the room. Imagine what that feels like. This might seem weird. It's so arbitrary. Left side of the room, right side of the room. But it's just as arbitrary where we're born, isn't it? If you're born in sub-Saharan Africa, left side of the room. Or if you're born in Europe, right side of the room. That's what determines whether or not you have access to a medicine. This is the beginning of the story of inequity. But actually, what I just described to you is inequality. It's not inequity. Inequality is when both of you are, I don't know anything about you, but roughly you're starting at the same place. One of you gets access, one of you doesn't. So what is inequity? I'm going to try something else. This one's a little bit more uncomfortable. I hope you'll bear with me. I need to divide the room again, and I was thinking whether to do it by hair color or height, and I'm looking around, and I think maybe height. So, does everyone know how tall you are? If you are 170 centimeters, or 5'7" for Americans, or taller, raise your hand. Okay, you're going to be the talls. It's an easy word to remember. Everyone else, you're the control group. So, the talls. I'm going to ask you, if you will, the talls in the room, to close your eyes, because this is hard to imagine. If you're a tall, imagine what it would be like if someone came, a group of people came, they were armed, and they took you away, because you're tall. Turns out the people who took you away believe that the talls are necessary to pick fruit from trees, because that's going to be their source of economic growth. So they need tall people. So the tall people are going to be taken. You're going to be taken from your families. You're going to be taken from the places you know. You're going to be taken to a place you've never seen before. And you're going to be forced to work. You don't have access to education. You don't have access to health care. You don't have access to contraception. So a lot of children are born to the talls. And you spend your entire life in forced labor. And your children do too. And their children do as well. For 250 years, your children, their children, their children, and all of your descendants live in a way, just because you're tall, and everyone, I'm assuming all the children of the talls are also tall, they are enslaved. But then, liberation. The talls are no longer forced to work. You can get a job of your own, but you live in a country in which there is enforced legal discrimination, in which your children go to different schools, or your descendants' children go to different schools. You don't have access to good health care. The places where you get to live are different than the other people in this country, this imaginary country. As a consequence, your land isn't as fertile, so you don't make as much wealth. And you spend 100 more years, your children, their children, your descendants, living in a way in which you don't have access to the same resources. Then, another 100 years goes by, there's an acknowledgement of your civil rights, of your descendants' civil rights. So now, the talls, their descendants, now there's no enforced discrimination. But by this time, have you been keeping count? It's 350 years later, the talls live in very different places in the country. They live in places where the lead content is high in the water. That affects your children's education. They've spent so many years living in a different way that, in fact, the tall's wealth is 1%. If you're a tall in this country, your wealth is 1% compared to the wealth of other people in the country. And even though there's not enforced discrimination, discrimination is still rampant. And what does that do to health? Well, tall women, turns out, are discriminated against all their life, so they have elevated cortisol levels. And so when tall women show up as soon-to-be mothers, they have a 2 to 3 times higher risk of dying. 2 to 3 times higher risk of maternal mortality because you're a tall. What about life expectancy? Well, because of all of these forms of discrimination, because of the impact of what it meant to be a tall 400 years after you were originally abducted, your ancestors were, life expectancy is lower. In fact, in some neighborhoods, the talls, neighborhoods dominated by the talls, life expectancy is in the low 60s. The national average is in the high 70s. So talls, on average, live 20 years less than everyone else. Those statistics are real. Those are the statistics of Black Americans. And that's the consequence of 400 years of slavery. And in the case of low and middle income and high income countries, when you think about that split, of colonialism, of exploitative capitalism, it's about race, not height, right, in the world we live in. It wasn't height. That wasn't the arbitrary characteristic that led to structural discrimination and injustice, generations of injustice. It was the color of people's skin. Or in the country that my ancestors are from, it was about caste. Our skin color is actually quite consistent, but caste is the determining factor of whether or not people were discriminated against or not. Or in other countries, some people here are from Kenya, it's tribe. Or in other countries like Afghanistan, it's gender. Some groups are marginalized by others, and it's typically because of reasons of creating wealth. That's why I was talking about the apple picking, tall people good at picking from trees. But as a consequence of that, people have fundamentally different starting points. That is inequity. It's different than inequality. Inequity means that you have a different starting point, and as a consequence, by the time you show up at a healthcare clinic, you're already far more likely to be predisposed towards negative health outcomes. Thank you for participating in that mental exercise. Cecile's telling me I have a minute left, so I'm just going to tell you a couple of stories of hope, a challenge, and a request. The stories of hope is, in the last 20 years, you're going to hear this from our colleagues, there's been a lot of progress on improving health for people, particularly in low-income countries. 30 million people have access to AIDS treatment. That treatment that Christoph is taking for $30,000 is available to Michelle now for $60. And by the way, the company that makes it, I used to work for it, still makes money. So a lot of people have access to medicine. That's great. 800 million children have gotten access to vaccines in the last 20 years. 15 million lives saved thanks to vaccines. That's amazing. In the case of COVID-19, in 2 years, we went from diagnosing the pathogen to having 12 billion doses of a vaccine that didn't exist 2 years prior delivered. That's incredible. And HIV, it took 30 years. It took 15 years to develop the good medicine. It took another 15 years to get it to 30 million people. 30 years down to 2 years. But the problem, when we look back at COVID-19 in the last 2 years, is that inequity still exists. Today, only 15% of people who live in low-income countries have gotten access to one vaccine. Only 1% of the tests given for COVID-19 have been administered in low-income countries. That is inequity. And so you're going to hear from my colleagues what we can do about tackling inequality and, I hope, inequity. My request of you, typically when I speak to an audience, I say, do you work for a pharmaceutical company or do you work for a marketing company? And I ask people to think about what they can do in their professional roles. But I'm actually going to make a request for you in your personal role, which is to feel accountability for inequity. I am the product of a country where the wealth and education that I benefited from was stolen from populations around the world. And so I now think of my work in global health, and I'll challenge you to think about your own and whatever you do as an act of redistributive justice so that we can be agents of change relative to those hundreds of years of injustice that I described to you, whether health is the outcome we're measuring against or anything else. Thank you very much.
Anil, thank you. All right, let me now call to the stage Nicolas Haugaard, Clément Dubois, and Alexandre Barral. All right, Nicolai, you're Senior Director and Acting Head of Global Health, Global Access to Health, sorry, Global Public Affairs and Sustainability at Novo Nordisk. You've been with Novo Nordisk for 6 years, and you also worked in the Danish Ministry of Foreign Affairs before. Clément, you're the CTO of EpiLAB. You're a French engineer in biology and medical biotechnologies and an entrepreneur. You have, interestingly, worked on beehives. I don't know if we're going to have time to talk about it, but I thought that was an interesting part of your bio. Alexandre, you're the International R&D and Growth Manager at Portal Telemedicina. You've worked in Brazil, in China, in Australia, and in France. Welcome to the three of you today. Thank you very much for joining us. I'm going to ask you to start with giving us the 1-minute elevator pitch of your respective organizations. Why don't we start with you, Nicolai? I think it's on.
It's on, yeah. Thank you very much, and thank you for inviting me. So Novo Nordisk, we are a global multinational healthcare company. We are almost 100 years old. Actually, next year we will turn 100 years. We are based in more than 80 countries, and we work within diabetes, obesity, rare blood disorders, and other rare disease areas. What we really try to focus on is to improve the access to type 1 and type 2 diabetes care, but also to innovate new types of treatments and make them rapidly and readily available all over the world. And that is a huge challenge that we will come back to a little bit more to talk about. Today, unfortunately, there are more than 500 million people living with diabetes, and there are more than 60 million that do need insulin but cannot afford it. So that is something we really, as a company, need to take responsibility for and need to change. I will end there.
Thank you. I think you were just on the 1 minute. Thank you. Clement, your turn.
Thank you. Tuberculosis is the first infectious cause of death of the 21st century, before malaria, before HIV. And when we realized that 2 years ago with my co-founders, we looked at the reason why. And the main reason why is that there is a huge diagnostic problem. Each year you have 10 million new cases in tuberculosis. And on these 10 million, you have 4 million cases who are undetected. So that's 4 million people who don't get the treatment they deserve and they need. And that's 4 million people who will be contagious and will be transmit the disease. So when you have 4 million people like this, you basically cannot eradicate tuberculosis. And why is that? Is because all of the diagnostic solutions require big machines, require infrastructures and qualified staff. And it's crazy when we look at COVID, and after 2 years we had a small test like that. And so with EpiLAB and with my co-founders, we created the first portable test for tuberculosis in order to reach people who are far away from health structures, and so that they can be diagnosed and treated. Thank you.
Thank you, Clément. Alexandre?
Yes. We are a Brazilian health tech company that provides a fast, reliable, and low-cost diagnostic through IoT and AI support. We first started years ago by connecting clinics to medical specialists. One of our first cases was in the Brazilian rainforest, a small clinic, and Paulo, the patient, was not able to consult because there is no cardiologist in the regions. So to solve this problem, we integrate directly and remotely all the medical data from medical equipment of Paulo to a medical specialist, a cardiologist in São Paulo, on the other side of the country. So that's our first delivery. We expand access to health by technology. The second delivery, by automations and a friendly user interface, we sped up the workflow by tenfold, allowing doctors, physicians to treat more patients and save more lives. And third and last delivery, we built a very strong AI platform that enables to predict pathology, determine a risk score, and organize the physician's queue by priority. So far we have 32 million patients, and we are growing worldwide. Thank you.
Thank you very much. Let's deep dive into our topic today. I'll start with you, Nicolai. So you're the big company in the room. You've been in business for over 100 years, or just about 100 years, like you said. What does accessible healthcare mean to a company like Novo? How are you actually structured around it internally? What does it mean for your business?
So for us in Novo Nordisk, it's really about democratizing access to healthcare. So it shouldn't be decisive whether you live in Europe, in the US, in Sub-Saharan Africa, in India, in China, whether you have access to healthcare. So that is really what we're trying to do, and we have been doing it for almost 100 years. So what we try to do is, we are a science-based company. We try to use our innovation, our knowledge about the disease areas to develop new drugs that can be made more available than those that already exist. For instance, thermostability is a huge problem in terms of insulin. So if you live in Sub-Saharan Africa, you don't necessarily have access to stable energy. But insulin needs to be stored in a fridge. It needs to be stored cold. So that's a huge problem. So for us, we really try to see how can we change that? How can we make an insulin that actually do not need to be stored cold? That would solve a lot of the challenges in terms of reaching insulin in Sub-Saharan Africa.
Thank you. So that's already start to talk about innovation and how we use technology. I'd love to actually go to you, Alexandre. Your organization, you're very, very ambitious in terms of your growth and in terms of the patients, the number of patients you want to reach. Can you tell us a little bit more about that? How do you make it work? How do you grow? How do you scale? And how do you reach the ambition that you have to develop your innovation and technology around the world?
For sure. So like I told you, we have 32 million patients, but we want to go, our big number is 1 billion patients. That's ambitious, but that's how we want to help access to healthcare. The pandemic has helped a lot on the regulations. For example, even in the United States, a very tech country, before the COVID, physicians in New York couldn't diagnose patients in Chicago, for example. So things are changing. So that's a good thing for the regulations. Second aspect I want to speak about, it's the interoperability. That's something we work much before working on AI. We work many years and we won many grants, R&D grants, working on interoperability. Because health sector, it's a very silo sector. And you cannot make a solution, so we couldn't make a solution that will work only for one brand, for one technology, for one country. So we make a technology that integrate with 90% of medical devices in the market. So that helps us to go in all the city and the village of Brazil, but then in South America, in States, in Europe, in Africa, in Asia, etc. And then the tech adoptions. We see as a patient, as a citizen, that we increase our tech adoption for health. For example, in France with Doctolib and other solutions. And also we have the other part, the physicians' adoptions. And sometimes when we speak about AI with the physicians, he can be afraid. And I understand it's something new in the sector for him. But we see the AI as a support, as an insurance. First, who is doing the diagnostic is the physicians. Then, or in the same time, but the physician don't see the technology, we apply our AI so that in the same times we have diagnostic, multi diagnostic in the same times. With one exams, we can look at COVID, heart failure, broken bone, or whatever, with 95% accuracy. So we bring that tools to the physicians to say, okay, you are in a very stressed environment. We ask you more and more things, but if you do any mistake, we have these technologies like a red button who say, okay, look at this, maybe you missed these very small nodules, and it can save a life. So that's how we want to expand.
Thank you. Thank you for that, and we'll come back to you later to talk to dive a little bit more on AI. Let's move to you, Clément, and to build up on that. I mean, your organization is even newer than Alexandre's organization. How do you actually roll? How do you make it happen? What's the deal breaker or the deal maker in a case like your organization? Brilliant idea, good solution, but how do you work it out?
I think we grow with the support of people, of foundations, of organization, of mentors, people. I think who feel accountable to help this kind of project. So we have many experienced people who just we reach out to. We just say we have a project on TB. I know you've worked on TB for a few years now. Could you maybe help us? Could you maybe connect me? And I think that's the first thing we have. It's the support of an amazing community. And we also grow with the team. You have to recruit the right people and recruit the right engineers to build the right product. I think it's really about support and about the community. There are many actions all around the TB world being done for what we are doing. It's been several years before EpiLAB that the WHO and then all of the TB world has been saying we need a new portable test. So when you arrive and say we are building a new portable test, you are being helped, and that's amazing. Thank you very much.
Thank you for that. Are you seeing any difficulties in bridging and building that ecosystem that you need?
Yes, because we are being helped, but one of the things we need is funds. But to get the funds, you have to be way more advanced, and I'd like to talk to you about that. No, I mean, people always, okay, this is cool, but come back in 2 years when you have clinical data. But how good do I get clinical data if I've not had funds? And when you go to see VCs, like people who fund, they say that's too risky. You're selling tuberculosis. It's a small market. It's in developing countries who don't have the money. Just please come back when you have clinical data. And so I need clinical data. And so that's one of the main difficulties. That would be the funding.
Right. Maybe you need to talk to Alexandre. He'll get you the data, and then you can expand. Thank you for that, Nicolai. Let's come back to you, and I'm interested to understand. So, a company like Novo, you always, you've been doing access for a long number of years. How do you continue to push and evolve yourself? But also, how do you do the partnerships with the companies, like the innovators, the one that have the new technologies? Like to what extent is that included into the work that you do, and how you do it, and what are some of the difficulties maybe along the way?
So first of all, I think partnerships and systemic change is the only thing that can solve the issue to accessible healthcare for all. I think that for us as a multinational pharmaceutical company, it is actually really difficult to partner up with anyone outside of our industry. So we are usually being seen as the big bad pharma industry. It's a reputation that we have put on ourselves, so I'm not trying to defend that. But the challenge is that if we really want to drive change, then we have to do it in partnership. And the way we in Novo Nordisk try to work with that is through examples, through ideas, through concrete actions. Then we try to show that we are actually not that bad to partner with. So in Novo Nordisk, we have made a partnership that's been running for more than 10 years. It's called Changing Diabetes in Children, where we try with local governments, with other suppliers, with funding from Roche, one of our biggest competitors in the diabetes space, to help children living with type 1 diabetes in sub-Saharan Africa to receive access and diagnosis. Because if you don't get diagnosed living with type 1 diabetes, you die. I met this girl, Olivia, she was 14. I met her in Côte d'Ivoire back in 2017. She really changed my perspectives and my view on what it is to live with type 1 diabetes. She shared her story about all the stigma that's related to her disease. But she also told me that she didn't know no one else living with the disease. So we try to do a lot in terms of bringing more awareness to the disease. And we try to do that with as many partners as possible. So we actually have a little bit the opposite problem. We are open for ideas, we are open for partnerships, but we are kind of lacking the right partners to engage with.
Thank you for that. Maybe you need to do a portable diagnosis for for diabetes, so you can connect. It's interesting that both Anil and both you, Nicolai, you've worked about the connections and the humans and, of course, the patients behind it. I'd like to go to the opposite side of this and come back to you, Alexandre, because you're working a lot on AI, so artificial intelligence. Super interesting, really, again, showing that technology innovation can bring a lot of solutions, but there are also some things attached to that, and particularly in terms of ethics and some big questions that you need to ask yourself as an organization. Can you tell us a little bit about that?
For sure, it's a deep question and reflections. We work a lot on ethic and bioethic. We were selected a few years ago by the Inter-American Development Bank to participate in a study, the Fair Lake study. And Portal Telemedicine was one of the main partners of this study. Of course, we work on anonymizations and other things, but the objective was to help government, the public sectors, to construct and to use AI in the good benefits for the citizens. So we work on two main topics that Portal is becoming maybe a reference or very good practical in the health tech sector. It's AI explicability, because AI cannot work in the same way, for example, in Netflix as in the health sectors. If Netflix show you this movie and not that movie, it's not that very important to know how is it do that. But in health, it's primordial, it's obligatory. So we construct some heat map to highlight the findings and to explain to the physicians and to the clinics. So it gives visibility and transparency to the system. The second topic is fairness analysis. When we build algorithm, and that's a big issue worldwide, that most of the time they are racist algorithms. They are built with man, white, in European or Occidental world. So the algorithm will not have the same performance with other ethnic, other people. So it won't work in the same way with a black woman and a white man. So we need to, during many years, we work for an inclusive algorithm. And that's one of the force in Brazil, that it's a country of 2 million people, very diversified. So we could apply our technology even on white, black, indigenous, Asiatic people. So to be the most performant everywhere. We want to expand worldwide, but we want to be performant and to not have exclusions of people, that everyone can benefit from the good advice of the AI.
Thank you for that, and that's really important, I think, to go back to the topic of health equity and how do you make sure that you don't continue to introduce bias into what you do when you use artificial intelligence for healthcare. We have a couple more minutes. I know that you also, we touched upon that when we spoke just before, and just to introduce the next session, maybe interested to hear how you actually work. Another topic that came was prevention. Very interesting to hear how a pharma company that sells drugs is actually interested into prevention. Can you tell us a little bit about this?
Yeah, absolutely. So I think, as a pharmaceutical company, as you also alluded to, it can sound very odd that we are interested in prevention because we make all of our money from treating people with the medicines, right? But the challenge is that the number of people that need medication is just huge. So no matter how many we prevent, there will still be a market. And I think there will also be a good business model, actually, if you figure out how to do prevention. So for us in Novo Nordisk, we invest quite heavily in prevention. So we have tried in Denmark to establish a public-private partnership with pension funds, with the Danish government, and with the pharmaceutical industry to try and look at obesity, which is one of the root causes that drives type 2 diabetes, and also a lot of other diseases, such as cardiovascular diseases and so on. And there we look at all the different decisions that actually impacts why you get obesity. So what you eat, how you exercise, how you live your life, and so on. So really trying to understand the socioeconomic factors around obesity. And that we do because we hope that by gaining that knowledge and also applying our knowledge as an innovation-based company, then we can find the solutions that can help people to take healthier choices and thereby actually prevent them from getting type 2 diabetes.
Thank you very much. Just maybe the one last question for you, Clement, you'll get the honor. What would you like everybody in the room to take away from the work that you do or the discussions with the discussion we just had?
Thank you, that's an amazing question.
Tough question, huh?
I think on health, the prevention subject is one of the most important. Which is in France, there's COVID, so we all know when we have a cough or when we have a headache, we go to get diagnosed. But in tuberculosis, it's just not the case because there are stigma everywhere. But one thing I will speak on our part, and this will go beyond health. There are many technologies around the world, around here, who are being invented by amazing scientists, and these technologies just stay in the lab and don't go after that. And so if you are engineers or if you have business people or just want to have some projects, I think anyone has the ability to go to talk to a scientist and say, okay, you have done this amazing research work. How could we do something? Could we resolve problems and issues with your work? So that's one of the things I've learned during these 2 years is that there are many inventions and innovations around the world who are just waiting to be taken and to be used to solve problems. So I'm going beyond health, but you can go and you have many ideas to take and you have many problems to solve. Thank you.
Thank you so much. Very inspiring. Very good answer. And yes, many solutions are out there. Many connections are out there to be made. So we hope that at least this event will help you make some of them. Thank you very much to the three of you, to Alexandre, Clément, and Nicolai. And I'd now like to ask Emilian to come on stage. Thank you very much. Thank you. Thank you. Bonjour.
Bonjour.
All right, this is supposed to be a fireside chat, so I don't know where the fireplace is. We definitely have the Eiffel Tower, so let's call it the Eiffel Tower side chat. I'll come next to you. All right, so Emilian, tell us a little bit about your own story and what drove you to come here today. Maybe you want to introduce also your organization first as a start.
Sure, Emilian. I've been in Africa for about 13 years, starting with doing a lot of management consulting, doing venture capital, building startups. But you know, after working hard and playing hard for many years, you know, I ran into some very deep healthcare issues. And one doctor told me one day, if I don't stop what I'm doing or I don't change anything in the way I live, I'm going to spend the rest of my life on statins and metformin. And this was a call for me about 7-8 years ago, and I started to really look deeper into my blood markers, the way I live, the way I eat, the way I move, and got into what I'm doing now, which is primary care or technology-enabled primary care in Africa. So trying to bring a small subset of what I do for my personal health by measuring a lot of biomarkers, by making lifestyle decisions based on numbers, trying to build a subset of this to the people around me. And it happens that I live in Kenya, well, spend most of my time in Kenya, a bit in South Africa. So bringing this to the people around me with a goal of improving the way they access quality care.
Very good. Do you want to tell us a little bit more about the things you do personally? Because very interesting.
Yeah, sure. Look, I strongly believe in... So I look at I look at the human body a bit like a car, right? So, and I often ask friends of mine who I see that they don't take care of themselves. I ask them, so you own a car, you go, and every 20,000 kilometers or miles, you go to a check, and then the car garage will plug some machines, and they will do some checks in your car, and then you prevent that your car runs out. But how often are you doing that for yourself? Never. Only when it breaks. So I strongly believe that, and then that Nicolai brought some good points on preventative care. I strongly believe that there's a lot of stuff we can do before things break. And look, I'm in my late 40s. I started to lose friends from heart attacks, from cancers, and I'm not talking about people who don't have access to care. I'm talking about people who live in the developed side of the world who could actually access whatever they need, but they still either they get very sick or they pass away. So what I do for myself, so I strongly believe in the kind of the 4 pillars of holistic care, which are activity, nutrition, cognitive, recovery, so sleep. I still remember until 7, 8 years ago when my mom was telling me you need to sleep, I was like, no, I'm gonna sleep when I die. And then I spent so much time and money in the past 6 years to try to improve my sleep, looking at my sleep data with my Oura ring, trying to understand how to improve my sleep to be able to be more efficient during my day, to be happier and healthier. So what I do, I walk barefoot as much as I can. I hike barefoot. I have a massive chest fridge home full of iced water, and I jump for 3 minutes every morning. And then I lower significantly my inflammation markers. I mean, I measure my bloods, obviously. I measure my CRP, my cytokines. So I can see actually I can see the results of what I do in my blood, in my happiness, in my cognitive health, in my overall health.
So prevention is
is
a way of life.
Yeah, and then that's maybe unfortunate for pharma companies because I haven't taken any meds for many, many years. But I try to avoid. Look, I believe in science, but I also believe that the human body is a pretty perfect machine, and we can do a lot of things before we need molecules to solve things. But obviously, when we need molecules, we need molecules.
Very good, thank you for that. Tell us a little more about the model of Ilara Health. I think it's a very interesting one, very innovative, somewhat complicated. So please give us the explanation.
Absolutely. So we build a technology-enabled primary care model for the emerging middle class in Africa. So just to put a bit of context, we often say that there's no access to care in Africa. Well, there's actually a lot of access to care. Kenya has 20,000 small primary care practices and about 40,000 chemists. France has, I don't know, maybe 6,000 GPs, I don't know, and maybe 10,000 pharmacies, I don't know, but significantly less. So access to care is actually very wide, but the quality of care is the problem. All those small medical practices are not run by doctors, are run by nurses or by clinical officers, who is a sub-medical profession. And when you get there, you may be given an antibiotic, and then you go, and then obviously it's not going to solve your problem. You come back, you're given another antibiotic. So bottom line, the care is extremely fragmented, lack of quality, lack of understanding from those medical practitioners for what those patients need to be given and how they need to be treated. So we believe that through giving those clinicians whatever they need to become better clinicians, we can identify the best ones among those 20,000 and support the best ones to become better clinicians, therefore to bring better care, therefore to deliver better care to the patient. So how do you do that? We started with diagnostics because this is something I'm super, super passionate about. So we started to bring diagnostic devices, so kind of like think of the mini laboratory, so a bunch of portable diagnostic devices, like the ones that Clement has or others, in those primary care facilities to be able to detect the basic metabolic markers, so your cholesterol, your blood pressure, blood sugar, your full blood count, your even kidney, liver panels, to be able to identify things before they really become bad. And then we continue. So we started with diagnostics, but then we continue with other things that those clinicians need. They make most of their money by selling meds. So we actually finance those meds, but we finance the better meds than the very cheap, low-quality meds. We finance those small practices more than just diagnostics and meds. We place Some of them, they want beds because they need to do some inpatient. Some of them, they want some other assets. But how do you do that? We place a technology platform on top of them, so we can understand their financial flows, their patient flows, their patient medical data, so we can identify the best clinicians and deliver whatever they need to become even better.
Who do you partner with on doing this? And I'd be tempted to say even more as you grow. Like, are you, how is partnership? How is collaborating with other organizations an important piece of what you do?
Absolutely. So look, I mean, our primary partners are actually the clinician, like, let's call them clinician entrepreneurs, right? So I strongly believe I don't believe into building new clinics in a market which has too many, but I believe in partnering with the best. So we need to identify the best first. But the second, because we build this layer above those many, many small primary care facilities, and we become a platform for whoever wants to and needs to plug services and products into those clinicians. So be it pharma companies, be it portable diagnostic device companies, being insurance companies, there is very, very little insurance penetration because there's no payment data or patient data. So we partner with all the players that need to plug into the primary care ecosystem in this mid to low income care population in Africa.
Are there partners that are more difficult to convince than others? Is the reception good on what you're presenting?
I think there's a lot of kind of misconception that primary care is not a profitable space, and there are a lot of companies who try not to touch that space. But unfortunately or fortunately, this is the space which delivers care to 97% of the people. Like, we talk about 2.7% insured people in Kenya, right? So I mean, in France, we're all insured, right? We all have the social security. Just 2.7% private insured and about 25% the national insurance, which doesn't really cover outpatient. But we've tried to demonstrate, I strongly believe in delivering value for everyone, and we've tried to demonstrate there is a way to build a profitable, economically viable model in primary care in Africa, and then it works.
Tell us about what you see as the biggest barriers or challenges that you've had as you built the business and as you're going to continue to grow.
So I think the first one is really fragmentation. And I often say, when I came to Kenya the first time, it was like 2015, I was living in a place where there were like 5 people selling or 20 people selling bananas in the street. And I was asking a friend of mine who runs one of the successful retail tech companies in Kenya, why there are 20 people selling bananas instead of being a supermarket? And he said, because no one has money to buy a fridge. So kind of like bring the comparison into care. No one has enough money to buy whatever they need to build a proper medical facility. So that's why there are like so many. So fragmentation is the primary challenge. Access to that many small clinics in the big outskirts of the city is not easy. It's operational difficulty, but even more than that is really the medical. I think Anil, you're talking about medical understanding of the deep science behind the care, because we're not talking about doctors, right? We talk to nurses who maybe have studied some kind of medicine 10, 20, 30 years ago. So it's really the lack of prescription of diagnostic, the lack of prescription of proper medicine. And that's very difficult actually because we're not financed to go and then train really. We're not financed to bring those clinicians back to med school. So that's one of probably those are the two big challenges. And the third one is that really we talk about out-of-pocket care, right? People pay from their pocket their $100, whatever they make a month, $100 to $200 per month per family. They need to pay for care, and obviously consultation is a loss leader, is zero, and they pay for meds and they pay for other things, but they pay out of pocket every time they need to go there. And actually, they go to see one of those clinicians only when things go really, really wrong, and then they pay whatever it takes to get better. So lack of a payer is probably one of the biggest issues.
How do you solve that? Is that the role of your company? Is that the role of others?
So for now, we solve when I look at healthcare, there are usually 3 actors, right? There is the provider, the care, there is the patient, and there is the payer, right? In most of those countries, the payer and the patient is the same, right? So for now, we've solved the provider side, so trying to help providers to become better providers and deliver better care, and we're going to move now into the patient care. So can we build an insurance model based on that network of primary care facilities that we kind of control, to be able to deliver some kind of subscription model, like outpatient insurance, into that network to the patients accessing that network. And the thing is that most of the people in those markets access this primary care, massive, wide distributed care system.
I have a question to you to get back to what Clément was saying earlier on, and the fact that there are millions of solutions out there, millions of ideas, loads of dynamics behind it, loads of people who want to do good. What made your solution doable? Like, what's the secret sauce for making something doable, making it work, and then scaling?
So I still remember one of our early stage investors told me, Emilian, you can afford not to make significant revenue in the early stage of Ilara Health. But one thing you cannot afford is not to understand, as well as those primary care providers, or even better than them, how do they think? And I was spending, actually, still spend most of my time in the field with those primary care providers. Sometimes I even go and camp. I mean, funny enough, I have a car with tents, and I go and camp in the village or in the outskirts, trying to spend as much time as I can with them to understand how do they think. So I think this is also what helped us to understand that those providers think day by day. They don't think, okay, I'm going to have a system which is going to improve my processes, etc. What can I sell or give to the patient for an exchange of cash, of money, for me as a clinician to make money and be able to pay my staff and to deliver better care to the patient? And this is something which so we've started to bring into those clinics products and services which bring an immediate cash incentive to that provider. And we started with those diagnostic devices. I do a blood test, I'm going to pay $3-4, and I'm going to get my full blood count done. I'm going to pay 50 cents, and I'm going to get my blood sugar, etc. And that's the basis. And then we started to come with anything else which, again, brings a cash incentive, a financial incentive for the provider, for the providers to make revenue, and for the patient, obviously, to benefit from this. So, and then only afterwards we brought a system, which obviously the system is very difficult to make money from SaaS models, from electronic medical records models in that market, where providers do not pay for systems. So we use the systems as a backbone and as a data collector platform to be able to identify the best providers and support the best providers with that product or that service, which makes them money for them to be able to survive and deliver better care eventually to the patients.
Thank you for that. How do you see your progression going so far? You're in sub-Saharan Africa. Are you planning on going to other regions of the world? Are there regions where it's more difficult, less relevant? What do you think?
No, look, I strongly believe that the decentralized care and the decentralized diagnostics model is something which is applicable to everywhere, right? And I mean, even if you look here, I'm not sure here in France, but if I step into a Boots in London or in a CVS in the US, I can do some blood tests, right? So kind of the idea of that centralized laboratory which cost $1 million to build is a bit obsolete, right? I mean, you can still do a lot of complex blood tests in a lab, but you can do a lot of tests at your provider and eventually home. I still see a future where we're going to have a machine home, and then put a finger inside in maybe 10 years from now and get a bunch of blood markers, and this is going to go directly to our providers, and the provider will call us and say, hey, come to see me because I see there is a problem, right? So this model works everywhere. Now, what we do in Africa, and specifically in Kenya, is a very, very simple part of this model. It's a simplified version of a decentralized care model based on data. Now, the way I look at the progress, we are now in about 1,000 of these 20,000 primary care small clinics in Kenya. 10,000 of them, so half of them are private. We're in about 1,000 of them, but 1,000 represent pretty much 30% of the total small providers where it is worth to do something, because the rest are too far, too small. So we've been very, very wide, and now actually get much deeper in the best ones. So there's a lot of work to do in depth in Kenya, But there are a lot of markets around first, so I wouldn't even think of outside Africa. There's a lot of markets around where we can replicate the same thing based on technology and identify the best clinicians and give them this clinic in the box, this perfect provider in a box with the devices, with the technology, with the knowledge to make them become better clinicians. And then we can go in other places in the world.
Easy.
It's actually not easy. It's actually, if it was easy, I think many other people would do it. It's not easy, but it's extremely impactful. It makes me so happy that I can see with my own eyes how patients going there now, they can avoid being amputated because of diabetes, right? Or waking one morning and not seeing well because of a kidney failure. So this is what makes me thrive and makes me happy, because we can make immediate impact with very, very simple things.
In a few words before we finish, if you had a magic wand, what would you do?
A magic?
Magic wand, in baguette magic. What would you like to solve in terms of healthcare?
It's really, I'm a big believer in prevention, and if I was, and I know it's very, very difficult in places where really people do not think of the future, thinking, what do I eat? Do I make enough money today to bring a piece of bread to my kids, right? So they don't think of eating healthier or living healthier or going for a run, etc., right? They have different problems. But if I'm able to solve at least the basics and detect the things that can be detected today and avoid that people get into type 2 diabetes, or even reverse, right? I mean, type 2 diabetes, if I'm not wrong, I'm not a doctor, but is reversible through lifestyle. So there are a lot of things we can do there. And if I manage to impact 100,000 people's lives today and then maybe 1 million people's lives in a few years, it would make me extremely, extremely happy. And I don't think that's a simple thing. There's a result of multiple actions into this ecosystem, and we're really building this ecosystem with different bricks by bricks. There's no magic solution in my opinion.
Thank you very much. This brings us to the conclusion, and thank you everyone today. I think today we've seen that innovation, technology, AI, you can stay here, it's okay. We'll just, are important. We also need dedication, persistence, vision, personal drive also that we've heard to really enable better access to healthcare globally. We've also seen that tech, innovation, drive are not the panacea. Access to health is a very challenging issue. That's why we still have half of the world population without there. So there are multiple layers to it and many, many things to still invent. Funding remains also an enabler. But overall, I think, and it builds very much on what you were saying, is that it's access to healthcare challenges actually need system-wide changes, and it's only the complementary capabilities of many different actors that can really help to move the needle on this. So I'll conclude on that. I thank you very much for attending. I hope this session was inspiring. I was very inspired by our speakers, so thank you very much to all of you. A warm thank you to Anil, to Nicolai, to Alexandre, Clement, and to you. And very much looking forward to continuing the discussion with all of you. Thank you, everyone.